So welcome back to the session. After mitral stenosis, the next favorite topic of the examiner towards the tail end of the cardiology, which we have almost reached, is mitral regurgitation. Once more, rheumatic heart disease is a very common cause. Additionally, mitral valve prolapse also can lead to the development of mitral regurgitation. Similarly, if there is any aortic stenosis very tight, then the left ventricular pressures can elevate and that can predispose to the MR. So, aortic valvular disease, acute rheumatic fever. Why acute rheumatic fever? In acute rheumatic fever, there is a myocarditis, carditis, which lead to development of the dilatation of the heart. When the heart got dilated, then the ring also get dilated and regurgitation will occur. So, acute rheumatic fever can cause. But that is a transient MR. Then myocarditis, dilated cardiomyopathy, hypertensive heart disease or even ischemia. Why ischemia? In ischemic heart disease, papillary muscles can suffer ischemia. They are unable to hold the cusps anymore and that can predispose to the development of regurgitation is what you need to remember. If there is acute infective endocarditis, those vegetations can make the valves become incompetent and can predispose to the development of mitral regurgitation. Similarly, hypertrophic cardiomyopathy and any collagen abnormalities like those who have Marfan's or a Ehlers-Danlos, they can develop the mitral regurgitation. There can be an annular calcification, rupture of the chordate tendineae due to the MI or infective endocarditis. Certain drugs, one of the favorite MCQ of the examiner, fenfluramine, cabergoline, they are known to lead to the predisposition to the mitral regurgitation. Now, what's the pathophysiology if there is a mitral regurgitation? Regurgitation will regurgitate the blood from the left ventricle, and when the left ventricle is undergoing systole, back into the atrium. So that will lead to left atrial pressure to elevate and left atrium to undergo dilatation. And there are two ways by which mitral regurgitation can be classified. One is called acute MR. That means left atrium is not dilated. It is not expecting regurgitation will be there. Suddenly there is a vegetation due to infective endocarditis and acutely there is a regurgitation, and left atrium is not prepared for that situation because it is not dilated, it is normal in size. And when acutely regurgitation occurs, the pressure in the left atrium will increase and that will reflect as a pulmonary venous pressure elevation, which will predispose to pulmonary edema. So pulmonary edema is a feature of acute MR, not chronic MR. Whereas, so once more, if there is an acute MR, which wave get affected? The other day we have discussed the JVP, right? So, left atrial V wave. V wave, why does it occur? When the atrium get filled by SVC and IVC, then the V wave will occur. If there is a regurgitant jet, what will happen? That regurgitant blood is coming and regular SVC, IVC blood is coming, together will be too much blood in the atrium and that will typically lead to prominent V wave. Prominent V wave in the atrium, JVP is what need to be remembered. Now, since the left ventricle's forward flow into aorta got stolen by this regurgitation, what will happen? Next time, when the ventricle gets filled, it gets the regular venous return plus this regurgitant blood together will then once more enter into left ventricle. So that is the reason what will happen, doctor? The stroke volume of the left ventricle will typically increase in these people. Now, what are the clinical symptoms? How does a patient present with MR? Until the cardiac dimensions are not increased, until the heart is not dilated due to this regurgitation, patients may not be able to show any symptoms. But the moment the cardiac dimensions increase, and the left ventricular stroke volume increased, that increased volume outburst from the heart into the aorta will lead to palpitations as a clinical presenting feature. So palpitations broadly can occur because of two reasons, doctor. Whenever your patient has palpitations, always remember. One is a volume overload state, where rapidly the blood is circulating from periphery to heart, heart to periphery, periphery to heart, heart to periphery. If that is happening rapidly, then palpitations occur. Second is any electrical arrhythmias, electrical activity of the heart, arrhythmias developed, that can lead to palpitations. So, patient's common presentation with mitral regurgitation will be palpitations. Later on, when pulmonary venous hypertension develop, dyspnea and orthopnea will develop because of the failure of the left ventricle. Why left ventricle will fail if there is a mitral regurgitation? Naturally, no. Normally left ventricles normal सीधा साधा job क्या होता है? क्लास को आना, बच्चों को पढ़ा के जाना घर को. That is the normal duty of a teacher. But he has got all naughty children in the class. Somebody had broken the table, somebody has snatched away the blackboard. What will happen to such a teacher? He fails. So, left ventricle is trying to pump the blood forward towards aorta. Some of the blood is running back into left atrium. Once more it is coming and sitting in the class. The left ventricle will be thinking, अरे हर एक बार मैं पढ़ा रहा हूँ, ये पास नहीं हो रहे और पीछे जा रहे और एक बार आके बैठ रहे. So left ventricle fails due to that extra unnecessary workload that it is imposed on. Then there can be fatigue the moment the cardiac output decreases. There can be cardiac cachexia. But how about thromboembolism? Thromboembolism is a main problem more so in MS than in the MR, is what you have to remember. But if you take the infective endocarditis, subacute infective endocarditis is more common in MR than in MS. This is the point which you have to be 100% sure. Now, if you clinically examine, what do you find in a patient who has mitral regurgitation? The dilated ventricle will lead to a laterally displaced diffuse apex beat with a systolic thrill. There is a soft first heart sound. There is a pan-systolic murmur. You can't listen first or you can't listen second heart sound. What you listen is only zzz, zzz, kind of a pan-systolic murmur is what you listen. And typically it is loudest in the apex and it will be radiating widely throughout the precordium, including to the axilla. The mitral regurgitation murmur. Then you need to remember, this is an example, classical example of pan-systolic murmur. Starts with S1, ends with S2. Neither you can listen S1 clearly, S2 clearly. What you listen is only the murmur. There's a pan-systolic murmur. So this pictorial in summary will depict you what are the important features of MR. In MR, the left atrium will enlarge. The left ventricle suffers volume overload and it will dilate. Increased left atrial pressure will kick back and lead to pulmonary venous hypertension. If it is acute rise of the pulmonary venous pressure, it can lead to in fact pulmonary edema. So, but pulmonary edema is a feature only of acute MR, not chronic MR. Ultimately, pulmonary arterial hypertension can develop and that can have effect on the right ventricle and that can lead to right ventricular failure is what you need to remember. The moment ventricle fails, what do you listen? You listen basically third heart sound. Third heart sound is not a feature if there is a pure mitral stenosis. Let me tell you, pure mitral stenosis में कभी भी heart enlarge नहीं होगा और कभी भी third heart sound सुनाई नहीं देगा. Only in MR, left ventricle fails, it dilates, third heart sound will be heard. That's a very important question. Ultimately, there is a development of atrial fibrillation, pulmonary hypertension, left heart failure, right heart failure, etc., etc. Now, if you take the chest X-ray, what do you see? Left atrium enlarged, left ventricle enlarged, increase in cardiothoracic ratio, which is a feature of MR, not MS. And valve calcification can also be seen. If you look at the ECG, what will you see? The bifid P waves and the signs of left ventricular hypertrophy. Earlier, what did we discuss in mitral stenosis? Mitral stenosis may, what you see is a right ventricular hypertrophy due to the significant pulmonary hypertension. Whereas in the case of the MR, left ventricle fails and hence there is a development of tall R waves in the left lateral leads, lead 1 and V6. Deep S waves in the right sided leads, that is the lead V1 and V2. So that is what you find left ventricular hypertrophy. About 50% of patients who have MR will be developing left ventricular hypertrophy is what you need to remember. Now you have done 2D echo. Then what will you find, doctor? You can discover what is the cause of MR. Is it due to papillary muscle rupture? And you can also quantitate how much MR, how severe MR is there by calculating the velocity of the regurgitant jet. Now, if you take MS, echo is a wonderful investigation by which you can quantitate, but it is not as definitive as in the case of the MS. In the case of MR, it is not that definitive, echo. If you do transesophageal echo, you can be able to discover whether there are any structural valve abnormalities that led to the development of the MR. And cardiac catheterization can be done to know how are the pressures in the various chambers. Now, how do you want to basically treat? Generally, you need to give surgical intervention, either by mitral valve repair or by replacement. And you need to basically treat the patient with vasodilators, ACE inhibitors, which will decrease the regurgitation, diuretics for a failing heart, and anticoagulants. So that's all the main part in the management of MR. So you studied MS means half MR is over. So that's the reason it took quite early to finish off this otherwise a very easy topic. Now the next important topic for us to discuss would be aortic stenosis in the order of priority. In the order of priority in which it commonly is asked in the entrance exam. So every topic will have 5 to 10 points, at least 2 to 3 gold medal points. If you are able to get the grasp of those 2-3 points on which examiner's mind is fixated, like that all 1800 topics in 19 subjects, if you are ready, doctor, nobody will stop you from winning the entrance exam in the top 10 ranks. Top 10 ranks. But you need to get what are all the general things about the topic, specific things about the topic, gold medal points about the topic. You must get the reasoning issues about that particular topic. And you must limit yourself. You can't be encyclopedic on all topics. What you need to do is, you need to focus. If you say general medicine, 125 to 150 topics. Entire general medicine. That means how many facts you need to master? Not more than 1500 to 2000 issues you need to know. What are frequently asked by the examiner. Okay, doc? So let's continue our discussion. Aortic stenosis. What is a common predisposing factor for aortic stenosis? A abnormal congenital bicuspid aortic valve. Bicuspid aortic valve is more common in the men and it will calcify in the later part of the life and can lead to development of a significant aortic stenosis. Of course, we are living in India where rheumatic fever is common, and that can lead to progressive fusion, thickening, calcification of the aortic valve leading to aortic stenosis. Aortic valve involvement is found in about 40% cases of the rheumatic fever, and usually a person has a bad aortic valve means he will also have a bad mitral valve. That's what you need to understand. So overall, if you take elderly people, it is the calcified valvular disease which is the commonest cause of the aortic stenosis is what you need to remember. And over a period of time, lipoproteins will deposit fat which will calcify, leading to stiffening of the aortic valve. At the time of the ventricular systole, where it is expected to open, it will not be ready to open. That's the whole problem. Now, there are three kinds of obstruction to the left ventricular outflow into the aorta, doctor. One is valvular level stenosis of the valves. Then you have supravalvular obstruction and subvalvular obstruction. So, supravalvular obstruction need to be remembered in aortic stenosis in relation to Williams syndrome. In this, what do you have? There is a congenital fibrous diaphragm above the aortic valve, along with mental retardation, hypercalcemia. The combination is called Williams syndrome, is what you need to remember. So this is what you need to know, doctor. In old age, there can be senile calcification, which can lead to aortic stenosis. There can be bicuspid aortic valve, which can undergo calcification. Whatever it is, that is responsible for the development of aortic stenosis. Now, doctor, what is the pathophysiology in aortic stenosis? Because of the aortic stenosis, the left ventricular pressure will elevate, and that lead to LV hypertrophy. And when the LV hypertrophy is, it wants more blood, it wants to drink a lot of blood. Hence, angina will develop. Then it can lead to arrhythmias, left ventricular failure, and because of that obstruction, the ventricle has a difficulty to empty into root of aorta. That means cardiac output get affected. If you are exercising, what do you expect? Ventricle to pump more blood into aorta, cardiac output to increase. But what is the problem in a patient who has aortic stenosis, tight aortic stenosis? When exercising, when there is a more demand for the cardiac output, the valve will say, I am stenotic, whether you exercise, whether you jump, whether you go and dance in ocean, cardiac output, this much only I will give you. Like a strict father telling to a son who wanted more pocket money, father says no pocket money. So that is a problem. That's the reason the dyspnea, the angina, the syncope, which are the cardinal triad of clinical manifestations of aortic stenosis, when will they be more? When the person is exercising, when there is a more demand. The stenotic valve is a fixed cardiac output situation. It will say, tum kuch bhi karo, itta hi cardiac output milega tujhe. Hence, it is an exertional dyspnea, exertional syncope, exertional angina, which are the cardinal manifestations of aortic stenosis, is what you need to basically remember. So, yes. So, Deva is asking, do we get all subject topic list? That's right. We are in the process of preparing. See, now we are starting altogether a new module, new way of approaching for the MD entrance. unlike what we have already delivered in our recorded videos of previous sessions. In the previous sessions, in the MDMS video library, you will find topic wise MCQ discussion of the previous PGI all India AIMS questions organized topic wise. And those topics are according to most commonly asked topics to least commonly asked topics in the subject. Then our new approach now is we will take the same topics, but we will summarize the common points asked, a comprehensive review of each of the topic. Every day we take up 5 to 6 topics and review those topics. And which topics to be reviewed on which day, that detailed Excel sheet we will update you latest by Monday morning on the Facebook page. Next 6 months until September 30th, before that we will finish all the 19 subjects in this new way. So we will give you that detailed which day, which topics. We will adhere to that schedule, and every day we have some 40 new questions as a quiz. We have a discussion included. So 5 to 5:30 will be the quiz, 5:30 to 7:30 will be a couple of hours of subject review, and another half an hour we will have a review of that quiz questions. So between 5 to 8 every day, Monday to Friday. And on Saturday, whatever we discussed that particular subject Monday to Friday, we will have a subject test. Actually, subject test will also have discussion every Saturday. Just now the students are coming up from the NEET shock, and they are now enrolling. So that is the reason we have not yet started the Saturday subject test discussions. So that will be started from next week onwards. So we will give you a complete schedule until September, every day, including what topics we discussed every day. So don't worry about at all. Now continuing our discussion with aortic stenosis, this is a classical graph. You have the left ventricular pressure, you have the left atrial pressure. So what was the effect of the aortic stenosis? The left ventricular pressure and the aortic pressure and the left atrial pressure, all of them got elevated because of the tight aortic stenosis. So you can see, in a normal person, it is around 10 millimeters of mercury in left atrium. It got elevated to 25 in aortic stenosis. Normal person left ventricle mein pressure is 120 by 10. That got elevated to 200 by 25 because of the aortic stenosis. So this is the typical pathophysiology of aortic stenosis. Now if you look at the left ventricular systolic function, left ventricle is like that strong army. You don't agree a failure in a Olympic game. Like a gladiator, it will fight. So left ventricular systolic function is preserved for a longer period of time in aortic stenosis. That's the reason if somebody had a bicuspid aortic valve with aortic stenosis, even with mild to moderate stenosis also, patient will not be symptomatic because left ventricle will try to compensate. But everybody will get BP, hypertension by the time it is 50, 55, 60. When he gets hypertension, what is the problem for the left ventricle? एक तरफ से narrow valve से blood को आगे बढ़ाना पड़ रहा है because the stenotic valve. On the top of it there is a hypertension. Left ventricle will say, sorry sir, I can be able to adjust, accommodate if it is only stenotic valve. On the top of it you keep big stone on my head, I won't agree with you. The moment hypertension develops in elderly people, a asymptomatic bicuspid aortic valve leading to aortic stenosis in spite of mild to moderate stenosis then becomes symptomatic. So that is a whole problem. It is unlike aortic regurgitation. In aortic regurgitation, what do you have? Patients will be symptomatic much earlier than that of the aortic stenosis is what I want to underscore to all of you. Now, when the aortic orifice is reduced to 1/3 its normal size, that is the time where you call it as moderately severe. At the time, patients will develop exercise-induced syncope, angina, dyspnea, all these things will typically develop. And when the symptoms occur, the prognosis is poor. Always, what is the rule in aortic stenosis? Most of the guys are asymptomatic, but the moment symptoms develop, exertional syncope, angina, and dyspnea, death will be within 2 to 3 years unless you did a surgical intervention. Note the clinical signs in aortic stenosis. Obviously, due to the stenosis, the ventricle is slowly pumping the blood into the aorta, and hence a small volume, slow rising pulse is what you typically come across. Pulsus parvus et tardus is what you have. Then if you look at the apex beat, since it is hypertrophy, not dilatation, hence apex beat is not displaced. In aortic regurgitation, it is dilatation. That's the reason apex will be found down and out from the midclavicular line, out from the 6th intercostal space. So it is dilated in aortic regurgitation, not in aortic stenosis. But if you look at the apex, it is a sustained apex. A hypertrophic ventricle is trying to push the blood into the aorta through a narrow valve, sustained apex. Sometimes a double impulse will be found in the apex. What is the reason? When the ventricular pressures are very high, atrium is trying hard to push the blood into that non-compliant hypertrophic ventricle. So that will typically create a kick, atrial kick, because of which a double impulse can be felt. Then in the aortic area, which is the second right intercostal space, there is a systolic thrill in this people is what you need to remember. And if you auscultate, there will be a ejection systolic murmur, which is crescendo, decrescendo in nature. It will increase and it will come down, kind of ejection systolic murmur. Suppose if aortic stenosis is more severe, this ejection systolic murmur also will become longer for the duration which it is heard. What is the reason? Because after all, a murmur is because of the passing of the blood through a stenotic valve. If it is more severe, what will it take? It will take much longer to pass out. Hence, a longer ejection systolic murmur means more severe aortic stenosis. Typically, the murmur is rough in quality. It is best heard in the aortic area, and it radiates into carotid arteries, is the typical feature of the aortic stenosis murmur. Now you see this the murmur of aortic stenosis. What is you call it as? Crescendo, decrescendo murmur is what you need to remember. Now, one common question asked frequently in the entrance exam, gold medal point, which I told you, which you have to be sure. How is the intensity of the murmur and its relationship with the severity of the aortic stenosis? Typically, intensity of the murmur is not an accurate measurement of the severity of the aortic stenosis. But we said it is a crescendo, decrescendo murmur. So, the shape of the murmur has a relation with the severity, not the intensity. The duration of a murmur has a relation with severity, but not the intensity. So, duration, shape, not intensity, has a relationship with the severity of the murmur. The moment the aortic stenosis worsens, it takes longer for the blood to eject through the valve. So the peak of the crescendo will move towards a later part of the systole. It is called late peaking. So milder aortic stenosis will produce early peaking of the crescendo decrescendo murmur. Severe aortic stenosis will cause late peaking. So when is the peak of the crescendo is occurring has a relationship. Duration has a relationship, but not the intensity of a murmur has a relationship with aortic stenosis. Now another common question asked in the entrance, which you have to be 100% sure, is how do you distinguish HOCM from that of aortic stenosis? What is HOCM? Hypertrophic obstructive cardiomyopathy, where there is an obstruction to the left ventricular outflow into root of aorta, but that obstruction is below the level of the aortic valve, where hypertrophied interventricular septum and the mitral valve leaflet come very close to each other and there is an obstruction. Now doctor, how do you distinguish such an obstruction which is subvalvular in HOCM from that of a valvular obstruction which you see in the case of the aortic stenosis? Already we discussed this point, I believe. Suppose you ask the patient to squat. Standing will decrease venous return. Squatting will increase venous return. If there is an increased venous return to the heart, there is an increased blood going into atrium, into the ventricle through the aortic valve, and a aortic valvular stenosis murmur will worsen. But an increased venous return to the heart will increase the chamber size of the ventricle and decrease the touching of mitral valve with the interventricular septum. So that is the reason HOCM murmur will decrease, aortic stenosis murmur will increase whenever there is a increased preload to the heart when the person is squatting, is what you need to basically understand. So what is the golden rule which you are going to remember? The intensity of the murmur is not a good guide to the severity. For example, if it is a very severe aortic stenosis, left ventricle is unable to pour at all into root of aorta. So then what will happen? The intensity becomes so much reduced. Though the aortic stenosis is very severe, hence intensity has no relationship. But the shape of that crescendo decrescendo murmur, when is the peaking occurring, how long is the murmur heard, they all have a relationship with the severity of the murmur. And how is the murmur radiating into the carotid? That's the reason a good number of times it is not uncommon in an elderly person that this radiating aortic stenosis ejection systolic murmur into the carotid in an elderly man may be mistaken for a carotid bruit, because elderly people means we think everybody will have atherosclerosis in the carotid, hence we are listening bruit, but that bruit is not bruit, it is the radiation of a aortic stenosis murmur which you have to carefully evaluate. And carotid stenosis, really if it is there also, syncope can occur. Aortic stenosis also can lead to the development of syncope. So all syncope should not be thought as carotid stenosis. You need to be careful. Then in this context we need to know what is meant by Gallagher's dissociation, which is one of the favorite question in the ward rounds. If you take the aortic stenosis murmur, normally it radiates into the carotids, but sometimes it can radiate into the cardiac apex. Who else is a systolic murmur who will also radiate into towards the apex, doctor? It is typically mitral regurgitation. So that is the reason this atypically apex side radiating aortic stenosis murmur can be confused with the mitral regurgitation's apical radiating systolic murmur. which is basically called as the Gallaverdin's dissociation is what you have to be very sure. Now what are the other important findings in aortic stenosis? Does a systolic ejection click due to the aortic stenosis? But remember, click is heard only in valvular stenosis. Any subvalvular stenosis or a supravalvular obstruction will not lead to click. Only when valve has undergone stenosis, and if it is a valvular stenosis, then only click is heard. So click is the cardinal auscultatory finding of only the valvular obstruction, is what you have to basically remember. Then the second heart sound become soft or inaudible whenever the aortic valve ultimately becomes immobile. And since normally aortic valve closes first, pulmonic valve closes later. But because the aortic stenosis, aortic valve becomes so delayed to close that it comes after pulmonic valve, which is called as reversed splitting. And because of that hypertrophied ventricle is non-compliant, atria has to use a lot of pressure to push the blood into the ventricle. Hence it leads to the development of a prominent fourth heart sound, is what you have to ultimately remember. So summarize, doctor, what are the two important things? Aortic stenosis, aortic regurgitation. How do you differentiate? Typically in aortic stenosis there is a systolic thrill, ejection click, a soft second heart sound, a fourth heart sound which is the atrial gallop, along with a systolic ejection murmur which is radiating towards the carotids, is what you come across in case of the aortic stenosis, is what need to be remembered. Now, if you take the chest radiograph, what do you come across? Typically we have a small heart because it is not dilated heart as in aortic regurgitation, with a prominent dilated ascending aorta is what you typically have. You may appreciate the calcification in the aorta, and the valve calcification can also be found. And if you take ECG, you have left ventricular hypertrophy signs and the pressure overload signs on the left ventricle, like ST segment depression, T wave inversion in the left sided leads V5 and V6 and AVL and lead 1 you will come across. And if the hypertrophy is significant, it can lead to ventricular arrhythmias. If you do the echo, there is a thickened, calcified, immobile valve cusp, left ventricular hypertrophy, etc., etc. Now, if you do the cardiac catheterization, what will you discover? Obviously, if you look at the aorta and left ventricle, due to the stenotic valve, lot of blood is pending on the ventricular side of the aortic valve instead of on the aortic side of the aortic valve. So that is the reason you will find that systolic pressure gradient across the valve between the left ventricle and the root of the aorta, which is graded by using cardiac catheterization. And what is the cardinal feature of the aortic stenosis? Angina. When will aortic stenosis is commonly seen? Elderly people. Elderly people, what is the other cause of angina? Coronary artery disease. So you want to do, before repairing the valve, whether the angina of the patient is because of his aortic stenosis or because of his underlying coronary artery disease. That's the reason it is a common practice to also do coronary arteriography to know whether there is any coronary vessel occlusion before you do the aortic valve repair in a case of aortic stenosis, is what you have to ultimately remember. Now, how do you basically treat? Valve replacement is the only option which is available for you for symptomatic patients. But if it is an asymptomatic patient, then you can do echo, you need to give antibiotic prophylaxis, you need to serially follow him on echo in asymptomatic patients, which is considered to be the part of the management. Suppose in an adolescent or in childhood, if there is an aortic stenosis due to a congenitally abnormal valve, then you will typically do the valvotomy, which is considered to be the management. And Is there any role for valvuloplasty in elderly people as an alternative to the valve replacement? Balloon valvotomy, valvuloplasty was tried, or if you are waiting for some time before doing valve replacement, for them also balloon valvuloplasty is still indicated. Then the new novel way of managing aortic valvular disease is a transcatheter implantation with a balloon expandable stent valve called percutaneous valve replacement is another option which is basically available. So doctor, this brings us to the most common issues with regard to the aortic stenosis. How does it clinically present? What is the pathophysiology? What is the specialty of murmur? How is its radiation? How do you differentiate it from HOCM? Etc. etc. You need to be very, very clear about. Now, before we say goodbye for this today's evening, I feel the remaining questions, 10 more questions are there. Why to leave them unanswered? So let us answer them and say that we have done a wonderful review of cardiology today. What was the question number we were last time, doctor? Question number where we left the quiz last time? Yeah, I think it was 20th or 21st. Last quiz was yes. Just another 13 to 14 questions are there. Yes. Very good. Jasmeet asked a question, why fibrinolytic therapy is avoided in, there is nothing called ST depression MI. ST depression is a sign of ischemia, not myocardial infarction. In myocardial infarction, you have two types, Q wave, non-Q wave, Q wave or non-Q wave. And in some people, ECG changes may not be evident, but there may be underlying MI. So only when there is a underlying acute MI, we need to give a fibrinolytic agent. And the ST depression is not a sign of MI, it is only a sign of ischemia. MI is myocardial infarct. Infarct has not developed, there is no thrombus leading to it. So there is a reason for you to give thrombolytic agents, either cardiac enzyme should be elevated or ST segment elevation should be there. Then only you can be able to give a thrombolytic agent is what, yes, Deva rightly said, Jasmeet may mean to say non-ST elevation MI, that's right. Okay, let's take up the question number 22. Verapamil, what is your answer, doctor? Verapamil is one of the subgroups of calcium channel blockers. So, will it lead to diarrhea or constipation? Is it useful in SVTs? Does it have any negative inotropic property like any other calcium channel blocker? Question number 22. What is your confident answer? I know you're all hungry for a dinner. Jasmeet proposes C, which says 2 and 4. 2 and 4. Any other answers from our online other classmates? It is only 4. It's only 4. Constipation is the most common side effect, and it is effective in treatment of SVT. Relatively it is much safer than the other calcium channel blockers when it comes to negative inotropicity. Probably 2 also can be included. 2 and 4 can be a relatively correct answer. That's right. Note the common side effect of calcium channel blockers. More than one answer? You like to choose diarrhea is anyway out of question. It is the constipation. Now you are all experts. So between 1, 2, 3 or 1, 3, what do you want to choose? Yes, we have corrected the earlier question answer as C. Okay. For this question number 23, what do you want to say? Does it lead to development of any anaphylaxis as a side effect? Very good. A good number of students said B, which is correct, which is only flushing and edema. As mentioned by Dr. Amrita and Deva and Jasmeet, it is 1 and 3, which is the correct answer. So, vasodilation leading to flushing, then cardiac depression, etc., they are all the important adverse effects. Now coming to deliriasm, what do you want to propose, doctor? Deliriasm, question number 24, does it have more negative inotropic effect than verapamil? Does it have lesser negative inotropic effect than nifedipine? Where does it stand in its inotropic, negative inotropic nature? Is it class 3 in the classification of antiarrhythmics? What is the effect of it on a non-Q wave MI when it comes to mortality? Question number 24. Very good. Jasmeet proposes only 2 and 4. She disagrees with option 3 and 1. Even Deva seconds Jasmeet. Very good. 2 and 4. It has lesser negative inotropic effect than nifedipine and it reduces the mortality. And it belongs to class 4 group of antiarrhythmics, being a calcium channel blocker, and verapamil has got a greater effect than nifedipine, which has greater than that of the deliriasm when it comes to inotropic effects. Now coming to amlodipine, what is your stand on amlodipine? Does it differ from that of nifedipine, nicardipine, nimodipine when it comes to the duration of action? What is its starting dosage? Very common drug given by house surgeons in the casualty. Can you give it safely in the patients who have congestive heart failure? And in dilated cardiomyopathy, is it safe to be given, or you don't want to give in the people who have dilated cardiomyopathy? Question number 25. What's your confident answer, doc? Yes. One confident answer from you. That's good. So, do we have any students from Pune? So, we have a online interactive, live interactive session in Pune on 5th, 6th and 7th. So, those 3 days since I'm not available, we will have the endocrinology part of the general medicine. We will have the previous recorded session which will be available for those 3 days. Just bear with me. After that, we will have all other classes live only without any recorded session. Yes. Question number 25. Jasmeet proposes C, which is 2 and 4. 2 and 4. Any other answers? Nursing Reddy proposes 1 and 3. Quite 2 different opposite poles. Nursing Reddy is absolutely right, which makes 1 and 3, which are true. That's good. Amlodipine is safe to use in patients with heart failure. It reduces the mortality in the non-ischemic dilated cardiomyopathy subgroup of patients. And initial dose is 5 mg orally once daily. And maintenance dose is 5 to 10 mg orally once a day. Half-life is 35 to 50 hours. And the starting dose is 5 mg daily. Now, question number 26. Give me one confident answer, doctor. With regard to the verapamil, once more. So today is all the drug day. Do you think it is contraindicated in asthma? Will it lead to bradycardia or tachycardia? Will it cause a decreased AV conduction as an antiarrhythmic? Is it metabolized by kidney or liver or nobody? What is your answer? Question number 26. Jasmeet asked the answer for the earlier question. Is 1 and 3? It is longest acting. It is safe for patients with severe CCF, and it is very much indicated in the dilated cardiomyopathy, not contraindicated. So 4 is out of question. So 1 and 3 are correct for the earlier question. We will also send all these questions with explanations PDF. So question number 26. Nursing Reddy says C. 2 and 4. He means to say it can cause bradycardia. It causes a decreased AV nodal conduction. Only 2 true statements in this, in his opinion. Okay, that's right. Nursing is absolutely right. It causes decreased AV conduction. It causes bradycardia. It is not contraindicated in asthma, and it is metabolized by the liver, not by the kidney. That's right. Nicorandil, one of the very, very important drugs which you need to confidently answer. What is the effect of it on thyroid function? Do you think headache is a side effect of it? Will it reduce the all-cause mortality of the mortality post PDCA? Does it have that any advantage in any of the studies? What is the mechanism of action of nicorandil is an important question. Question number 27, very good. Nursing, Jasmeet stand on the same point. 1, 2, 3 are right, not D. No sir, 2 is not included. 1 and B, 1 and 3 are correct. Nicorandil has that venodilating property because of that nitrate group which is there in its structure, and it causes headache because of that nitrate group. It's a potassium channel activator which has a nitrate as a part of it, but it has no effect in improving the mortality in post PDCA. Now the next question, a 55-year-old on multiple drug therapy, simple question, which are P450 inducers and inhibitors? You have to be 100% sure. Question number 28, yes. What is your answer, doctor? Question number 28, who are the inducers and inhibitors? Very good. Jasmeet comes up with the answer 1, 2, 3. Oh, Deva says B, only 1 and 3. Inducers we are talking, right? Oh, okay. Cimetidine, inducers and inhibitors, right? Ketoconazole, clarithromycin, allopurinol, they are all inhibitors or inducers, doctor? Who is an inducer? Question number 28. They are not asking inhibitors, inducers. Now, question number 29. ACE inhibitors, what are the important drug interactions you are not going to forget? Will it interact with digoxin, lithium, erythromycin or diclofenac? What are the interactions of some interactions are very well known interactions of ACE inhibitors. 29. What is your confident answer? Yes. I am waiting for your answer basically. Question number 29. That's good. Tara, Jasmeet, both of them propose 1 and 3. They don't want to include 2. Why not? Digoxin also is included. ACE inhibitors and antihypertensives. If you combine them with digoxin, it is known to cause a decreased antihypertensive effects. So digoxin is very much included. Now, with regard to the ACE inhibitors, once more, in relation to the effect of it on potassium, diclo, sure. Yes, we are also sure. That's good. ACE inhibitors, what is your answer, doctor? Can it lead to cough? If so, then what percentage? Can it lead to hypo or hyper? What kind of kalemia? Can you give it in asthma? I think answer is evident over there. Right? 1 and 3 are correct. Already answer was given. Okay. No big deal. No, only 1 and 3. 1 and 3. B is not hyper, doctor. Hypo, not hypo. Hyper. Jasmeet can't do this mistake. Hyper. Kalemia, not hypo. Okay. Question number 31. Quinapril on angiotensin 2 and serum renin. What is the effect of quinapril? Quinapril is big brother of enalapril, let us say. What is the effect of it? Obviously, an ACE inhibitor should do what? Prevent angiotensin 1 to 2 conversion. Right? So, who should decrease? Who should increase? Question number 31. 31. Who will give the correct answer? That's right. Angiotensin 2 will decrease and that stimulates renin to increase if you are giving an ACE inhibitor. Very good. Jasmeet rightly answered. Now, simvastatin. You need to be very sure. What are the effects of simvastatin? Who will give me the correct answer, doctor? With regard to statins, do they have any effect on the muscle and rhabdomyolysis? What is their mechanism? Which enzyme do they really inhibit? What is the role of them? Can you give it in pregnant women? And how much time does it take for them to start showing up their effects? Question number 32. 32. I am waiting because it's a long question, you will take a time to decide. But you need to take the quiz beforehand so that you are more confident. Question number 32. Yes, very good. Deva proposes only 4 is correct. Because he is confident about only 4, which is correct in fact. Very good. Amrita also thought the same, only 4 is correct. It won't cause fatal rhabdomyolysis, but it leads to myopathy, which is true. Then, with this we will conclude the today's session, doctor. So, we will see you all tomorrow at afternoon 1 o'clock, 1 to 4 o'clock. We have a discussion of a 200 marks paper which is being said by Abjuda. And to all our online students, we will try to send a PDF of that paper tomorrow morning. You can solve that paper so that afternoon you can actively participate in discussion. So that's all for this week. Thank you, doctor.